Okay, I think we're going to get started. If that's okay with everyone.
Great.
All right. So good afternoon, everyone, and thank you for joining us for the Pearly Health Center of Excellence webinar series. My name is Danny Sinden, and I'm the director of the Center of Excellence. Pearly Health is a unique and innovative campus of care, home to more than 600 seniors and veterans living in independent apartments or receiving long-term care. Pearly Health is also a center for research, education, and clinical and therapeutic services. The Pearly Health Center of Excellence leads and participates in innovative initiatives, research, and knowledge translation activities that help advance quality of care for older adults living with frailty. Before I introduce our speaker for today, I just want to let people know that there will be time at the end of the presentation for questions, and you can do so by entering them into the Q&A box at the bottom of your screen. So you can feel free to enter your questions at any point, and we'll try to get through them all at the end of the presentation. We also ask that you take a minute or two at the end to complete the short survey that will appear on your screen when you exit the webinar. We are very fortunate to have Dr. Marnin Heisel as our featured speaker today. Marnin is a clinical psychologist and professor at the departments of Psychiatry and Epidemiology and Biostatistics at the Schulich School of Medicine and Dentistry at Western University. He is also a scientist at the Lawson Health Research Institute. Dr. Heisel's research focuses on the promotion of psychological well-being and the prevention of suicide among older adults and other at-risk groups, and has included the development and evaluation of psychological assessment tools and interventions, and the provision of educational training for healthcare providers. I've had the pleasure of collaborating with Marnin over the last several years on the online meaning-centered group project that he will be speaking about today. And so it's really exciting to hear about the results and to be part of this. So I'm really looking forward to today's presentation. So without further ado, please welcome Dr. Marnin Heisel.
Excellent. Thank you very much, Danny, and thank you very much, everybody, for joining us, and to the Center of Excellence for inviting me to be with you today and to talk about our groups. So let me just, there we go. Hopefully everybody can see that all right and hear me okay. So I will get going and share some of our findings, as Danny mentioned, about our study looking to promote psychological well-being and reduce distress in older Ontarians, giving you some of our initial findings from our online meaning-centered group study. There we go. And this is for those interested in reaching out, getting in touch with me, finding out a little bit more about our projects, or giving any feedback. Here's how you can reach me. Email is probably best. And our website is available, I believe, down below there as well. Excellent. So if we were to start a sort of cold open, take a moment now to think about your life as it is now and ask yourself, what's meaningful in my life? Or if it's a little bit easier, what makes my life meaningful? What lends meaning to it? Maybe what makes my life worth living? And just take a moment and think about that. We'll come back to those questions in a little while because they're highly relevant to our discussion today. So today, as you've seen, we'll talk about the role of meaning in life in helping to enhance psychological well-being and reduce distress in older adults. You'll hear a little bit about our online meaning-centered groups, or yes, OMG, aimed for people experiencing loneliness, social isolation, or psychological distress. And here's some preliminary findings from our OMG study that was initially designed for older residents, well, not that older, 60 and older residents of Ontario retirement homes, but which we expanded to include other Ontarians living in community settings with family members, etc. So here's a brief sort of quote unquote warning label. Because we'll be focusing on topics related to mental health and well-being in older adults, we'll also talk about the opposite a little bit, issues related to psychological distress and even prevention of suicide. with that in mind, we know that these topics can potentially be distressing, that some of them might impact you in a particular way, depending on what you're experiencing or experiences you've had with others in your life. So make sure to take good care of yourself. Use your judgment. If you're finding it to be a little bit too much, you might want to mute the session or temporarily leave, or stop attending if you're finding it to be a little too difficult. It's certainly not the intent, and we'll try and keep things on a more positive note. But don't feel free to turn off the sound or to leave if you have to, and certainly feel free to put a note in the chat box if you're finding it to be a bit too much. And just to remind, it's always a good idea to know about various resources available in the community, and we've listed some of them right here. Okay. With that in mind, a little background on the current project. Well, in late 2019, which in some ways feels like yesterday and in others a world ago, I attended the annual conference of the Gerontological Society of America, which took place in Austin, Texas. At that time, I presented some new findings from a longitudinal study that my colleagues and I had conducted a few years earlier, investigated an important question relevant to the health and well-being of older adults. You see, we'd been hearing some worrisome news from overseas talking about the impending spread of a terrible epidemic that threatened the health and well-being of older adults and potentially contributed to risk for death, for mortality. I think you all know what I'm talking about. Loneliness. No, you were thinking of something else? No, loneliness. News at the time was spreading from the UK about the findings of a report by the Joe Cox Commission on loneliness, which pointed to the existence of a so-called loneliness epidemic. Physicians soon afterwards began engaging in what was called social prescription, where they would actually take out their prescription pad and write out a prescription for some of their patients to engage in social activities, especially for those who were feeling lonely or socially isolated, because this report indicated that loneliness could be associated with health problems, and potentially even risk for mortality. Loneliness, which can be thought of as the subjective or internal component of social isolation, has been shown to be associated as well with thoughts of death, thoughts of suicide, or even suicide behavior and death. And so it's a highly important topic. This focus has exploded around the globe. Here you see last year the cover of the US Surgeon General's advisory report on loneliness and social isolation. Certainly in Canada, there's been a huge focus on it as well, in many countries around the world. But the UK took it a step further, and the Prime Minister took the unprecedented step at the time of creating a new ministerial office, which was actually called the Minister of Loneliness, which I joked sort of tongue-in-cheek as being both, highly innovative and yet what sounds like a very depressing job title. Nevertheless, I understand that the Ministry of Silly Walks is still something that only exists in the minds of Monty Python, but there is a Minister of Loneliness. I think the UK is currently on at least their third Minister of Loneliness, and other countries, I believe, have followed suit as well, taking the issue of loneliness very seriously. Now, as I mentioned, the experience of loneliness can increase risk for despair, illness, mortality, and even suicide risk in older adults. It might be absolutely self-evident why it's important, but let's take a moment to talk about why that is. Well, the older adult population is growing, as we know. People are living longer, which is a very good thing, and we've generally done a good job, healthcare providers, scientists, public health scientists, at reducing mortality related to some of the conditions that led to shorter lives merely decades ago. Up until the COVID pandemic, infectious disease wasn't having the same impact on shortening lives as it had been in previous generations. And we know that the older adult population could grow to exceed 1.5 billion people within the next quarter century. In fact, we anticipate that a quarter to 1/5 of the North American population could be over the age of 65 within coming years. As we see here in 2019, before the pandemic started, we reached a point in history at which there were more older adults alive in the world than young children under the age of 5. We see as well, and this is again some older estimates, that within the next 5 to 15 years, we'll have, again, 1 in 4 to 1 in 5 Canadians will be over the age of 65. And if we look back only 100 years, fewer than 5% of Canadians were over those ages. So this really amounts to a huge demographic shift in the way that the population of Canada looks. What's important to realize, as I think we all do, is that mental health is integral to health in general and certainly to healthy aging. As we get older, we might experience a variety of life events and transitions that can challenge our well-being. However, it's important to recognize that psychological problems, mental health difficulties are not an inevitable component of aging. Just as it's true with heart, lung disease, and other issues, depression, anxiety, severe memory impairment are simply not part and parcel of growing older, but are health problems that can be identified, that can be treated, and ideally can be prevented. We know as well that most middle-aged and older adults are emotionally well-adjusted, but we do know that various health conditions, social factors, including loneliness, can erode mental health and well-being, can potentially impede life satisfaction, and can worsen life experiences for older adults. In 2017, the World Health Organization reported that roughly 15% of adults over the age of 60 have a mental disorder which can contribute to poor life satisfaction, decline in functioning, and increase risk for death, including by suicide. And as many of you might be aware, if not, you will, older adults have among the highest rates of suicide worldwide, and that's certainly true in Canada as well, and that's especially the case for older men, which doesn't mean older women aren't at risk, but as we see here, these are data from Statistics Canada that I plotted a while ago for suicide rates in 2021. So these are deaths by suicide. We see early in life, we don't see much in the way of suicide behavior, which doesn't mean that children don't tragically end their lives. Some do, but they're considered incapable of forming legal intent. So we really don't see much in the way of suicide rates until about the age 12 to 14, which is why it goes from essentially nothing to a jump in those years. Just to help you understand what we're looking at here, in the blue, we see rates of suicide for males, in the pink or fuchsia for females, and green, everybody overall. And these are the categories that StatsCan provides us with. So we see this jump in teenage years, a plateau in midlife, reduction in later midlife, and then an early to mid older adulthood. For women, the rates tend to keep declining. There is a bit of a secondary increase in later life here. For men, we see an increase in the 70s that just keeps going up and up and up. 2021 was a somewhat unique year, and I would argue that some of this might be the impact of COVID and various other factors. Typically, this line here just continues going up and up and up, with older men having the highest rates of suicide in Canada. In this particular year, actually, young to middle-aged men had slightly higher rates, which typically does not occur. Typically, we see this curve is a little bit lower, and this curve just keeps rising, which is the same in the United States, in much of Europe, and in much of the world. So, irrespective of specifics to 2021, we see that suicide is a major issue among older adults, and it's one that's increasing. If we go back over the last 20 years, we've seen that rates of suicide have gone up and down for all age groups, but overall, there hasn't been a massive change over time. There had been increases, then it went back down again, but the numbers are relatively similar or comparable, at least for these 2 years, 2000, 2021, over the lifespan. For older adults, though, we see a massive increase, nearly a 60% increase, as we can see here. So these are the numbers, not rates. Rates, which I showed a moment ago, are standardized per 100,000 population members. These are the actual numbers. where we see men, women, and overall increase from roughly 400 deaths roughly 20 years ago to close to 750 deaths a couple of years ago, and more recently down to 620 some odd. What's important to recognize, though, and as we look back to 2016 or so, where there was a slight dip, those figures don't include MAID or deaths by medical assistance in dying. So MAID is not considered equivalent to suicide in the law or by the Canadian government. And so, in fact, Statistics Canada data do not include medical assistance in dying. Those data can be found separately in reports from the Federal Health Ministry. This is important because MAID, and people often don't say this, but MAID is most commonly accessed by older adults. In fact, in the year 2022, for which the most recent data were available, the average age of Canadians who accessed medical assistance in dying was 77, and 85% of those who accessed MAID were over the age of 65. And we know, especially we get into later years, despite what we've seen in suicide, when far more men die than women, with MAID, once you get into the later years, it reverses. Overall, it's roughly a 50-50 split, but once you get into the late 80s or early 90s, we see more women than men dying of MAID. We see as well that there have been massive increases in the number of Canadians who have accessed MAID, with over a 30% year-over-year increase since 2019 COVID pandemic. And we'll come back to that in a moment. This is just to show, again, the sex differences between women and men and over the life course. What's a final comment on MAID for now is that the government and physicians and nurse practitioners who are speaking with people who are contemplating and requesting assisted dying ask them for reasons why they're thinking of MAID. And you'll see in a moment what the various reasons are. The number one reason, and this surprised me despite the fact that this is something that I've focused on for many of years, the number one reason given by 86% of those who wished to access MAID was perceived loss of the ability to engage in meaningful activities, as we can see here. So concern about the loss of the ability to perform activities of daily living was a close second. Pain control was a somewhat distant third, followed by loss of dignity, concern about other symptoms than pain, etc., etc., etc. Interestingly, and a palliative care colleague of mine pointed this out, 17% indicated isolation or loneliness was the reason why they were contemplating suicide. So again, this brings us back to what we were talking about before, but this concern about loss of the ability to engage in meaningful activities will take us forward to our OMG groups in just a few moments. So all of these data suggest a desperate need for public health programs that focus on promoting the search for, recognition of meaning in life, as well as improving pain control for those suffering with severe health issues and receiving palliative care, and the need to enhance social connections. These are critical. And that's really the topic of our discussion today. So I'll step back and say, as we know, and we've heard this said before, human beings are social animals. In the late 1890s, Emile Durkheim, who was one of the fathers of sociology, as one of the first studies of sociology, focused on demographic rates of suicide in Europe. And he showed that there was a close link between social factors, including social support, and suicide. Nearly 100 years later, American psychiatrist Jerome Motto conducted a study in which he really wanted to find out whether social support could in fact be life-saving. So what he did was to reach out to people who had been inpatients of mental health facilities who were no longer in touch with their providers. He randomized them, so he used a statistical program to divide them into one of two groups, strictly randomly. One group was sent brief typed letters, which they wrote ahead of time, simply reaching out to them, saying, "We know we haven't heard from you in a while. We hope you're doing well. We hope things are going well. Feel free to reach back out to us." The other group got no letters and just, were left as they were, which was typically what happened when people no longer involved with their healthcare providers. What they found, if somebody responded to the note, they would then send another note. Great to hear from you. Glad to hear things are going well, or sorry to hear you're struggling a little bit. We hope things continue to go well, continue to improve. Feel free to reach out again. They had a series of 8 letters that they would send in response if somebody wrote back. If they didn't write back, they would leave it at the one note, and that was it. That was the whole intervention, sending out a letter to those who were no longer in touch with their mental health providers. What they found after a period of time is that the people who received the notes were significantly less likely to kill themselves than those who didn't receive them. A very easy intervention, and yet one that appeared to be highly effective, suggesting that human contact in and of itself, feeling like you matter, feeling like somebody cares enough to reach out to you, to simply ask how you're doing, can potentially be life-saving. Other people have since replicated that study. Some have found similar results. Some haven't found quite as strong an effect, but it seems to be a very easy thing that can be done, and one that can potentially reduce risk for suicide. Now, going back to the issue of loneliness, people have found that loneliness has been associated with thoughts of suicide and suicide behavior in population-wide studies, so large studies, whether in Quebec, as we see, in the UK, in Spain, and elsewhere. One set of researchers conducted a systematic review where they pulled together a number of findings from published studies looking at qualitative studies. So unlike our study, which we'll talk about, which more focused on quantitative studies, looking at numeric findings, these were, again, internal experiences people might share through interviews and that sort of thing. And they found 3 factors were associated with self-harm in older adults. 1, feeling that somebody had lost control. 2, feeling lonely and isolated. And 3, finding aging to be burdensome. That's highly relevant to a more recent, almost 20-year-old theory developed by a colleague, American psychologist Thomas Joyner and his colleagues, which was an interpersonal psychological theory of suicide, which links risk for suicide to at least a couple of social factors. 1, feeling of being socially disconnected or excluded, and another, feeling of being a burden to others. They found that those 2 factors, together with the ability to engage in suicidal behavior, were highly associated with suicide thoughts, behavior, and death. Again, coming back and suggesting that feeling socially connected can potentially be protective against suicide thoughts and behavior. And maybe just a little bit more, this from late American researcher John Cacioppo from Chicago, who outlined a number of processes by which loneliness could in fact increase risk for illness and death, including evolutionary factors through medical decision-making, health behaviors, lifestyle stresses, etc., etc. Some researchers have even suggested that there may be a genetic component to the experience of loneliness. Whatever the possible processes or mechanisms involved, however, what's absolutely clear is that loneliness is associated with negative health behaviors, negative processes, and negative health outcomes in later life, and therefore deserves attention. So what did we find in this study that I presented in the States? Well, what we wanted to do was look retrospectively at some data we had collected some years earlier, which was a 2-year longitudinal study designed to look at risk factors and positive factors to see if they were associated with depression and/or thoughts of suicide in community residing adults over the age of 65. So we recruited people, 175 people in the London, Ontario area to come into our offices, gave them a number of measures, cognitive functioning, physical functioning, mental health and well-being, as well as negative psychological factors. And we invited them to come back a number of times over the next 2 years, a couple of weeks to a month later, 6 months to a year later, and a year to 2 years later. And the main idea of the study was to see whether older adults who reported finding life to be meaningful at the beginning of the study, what we call our baseline assessment, did that protect against developing symptoms of depression, or thoughts of suicide over the next 2 years, even taking into account negative life events and transitions that they might have gone through. One of the measures that we administered in that study was a common measure of loneliness called the UCLA Loneliness Scale. And those were the findings that we looked at in this study. But I will sort of hint ahead a little bit to say our study did in fact show that older adults who reported more meaning in life were protected against thoughts of suicide. And I'll share a brief aside here. The idea for this came from my doctoral dissertation study, which goes back to, well, the turn of the millennium, 1999, 2000, where I was going into older adults' homes, into health programs, into hospitals, retirement homes, long-term care homes, to develop a measure of suicide thoughts in older adults. And so I would speak with different people who staff had outlined might be interested in participating and ask them a variety of questions similar to some of these. And I remember speaking to two women. They were neighbors, so I spoke to one in her apartment, then the others in her apartment, and asked them questions about how they were doing. Both of them were in good physical health. Both of them were in good emotional health. They weren't depressed, they weren't hopeless, they weren't thinking about suicide, they were in good physical health, they were generally doing well. When asked about thoughts of meaning, one of them said, no, my life is no longer meaningful. There's nothing meaningful or purposeful going on in my life these days. The other one, her neighbor, said exactly the opposite. My life is filled with meaning. I love it here. This is a great home. They take good care of us. We have art. We have music. I get people visiting all the time. I even like the food here. She was very happy and found her life to be meaningful. As I was leaving and driving home, I sort of scratched my head and thought, my sense would be that somebody who said that their life isn't meaningful should be depressed, but she wasn't. As I looked at it further and thought about it further, and I'll introduce you to the theory and the research of Viktor Frankl, who had been an Austrian neurologist and psychiatrist who lived through much of the last century. He said that asking about the question of meaning in life, what's meaningful of my life, isn't necessarily a problem. And in fact, even feeling that your life lacks meaning isn't necessarily a problem, provided that you use that as the impetus to go out and to try and find more meaning in life. So in fact, the fact that neither of these women were struggling, that the one who said, I don't see anything meaningful in my life, wasn't despairing, maybe shouldn't have been a shock. But I then sort of looked towards the future and thought, of those two, if both of them were to experience some sort of downturn, physically, emotionally, in their relationships with their families, maybe financially, what would happen? My concern was that the person who said my life isn't meaningful might be at increased risk for struggling emotionally, for becoming depressed or worse. And that was something that we wanted to test in this study. So that's why we brought people in, asked them how they were doing, and followed them over time, expecting over 2 years they might experience some of those challenges. And what we found, as I alluded to, those who reported finding life to be more meaningful at the beginning of the study were protected against thoughts of suicide over the next 1 to 2 years. And that's consistent with a theory that we have, which essentially says people experiencing psychological, social, environmental, even biological risk factors might be at increased risk of thinking of suicide or acting on those thoughts, either on their own or together with negative life events or precipitating factors. Whereas those who experience more resiliency factors, potentially including meaning in life, should be protected against some of those thoughts. And again, that's what we found in that one study. So back to the issue of loneliness. Again, we used a brief version of the loneliness scale. We recruited 173 older adults, on average age 74 years. Most were women, 122 women, 51 men, most born in North America, many of whom were retired or volunteering, generally high levels of education, et cetera, et cetera. What did we find? low to moderate loneliness scores given, but we did find that about 1 in 5 scored at slightly higher levels of loneliness. So some people were, in fact, struggling with that. When we looked at associations between loneliness and social and psychological factors, we found no association between loneliness and number of kids or grandkids. You might think that having more grandkids would mean less loneliness. We didn't find that in that case. But what we did find is people who reported more loneliness reported less perceived social support, poorer psychological well-being, more depression, and more interpersonal hopelessness. And that's essentially what we see here. We also found that people who reported being lonelier were more likely to report having attempted suicide at some point in their life, and currently reported being more likely to think of suicide, to wish to die, to experience that they'd lost personal worth or social worth. They were feeling socially disconnected or lacking in worth, and were more likely to report feeling that life was not meaningful. We also wanted to look at, using the strength of the study, which is its 2-year period, and we wanted to see whether people who at baseline reported more loneliness were more likely to experience increases in thoughts of suicide over time. And that's exactly what we found, even taken depression into account. So all of that suggested that there seems to be strong importance in enhancing social connections and support for older adults, especially for those feeling socially isolated. And those issues only became all that much more important in late 2019 and beyond as the other pandemic took center stage. In fact, we all know that older adults, especially those with immune compromise and who were more socially isolated, were unequally impacted by COVID, were more likely to get sick and more likely to lose their lives as a result. As a result, we know as well that social isolation is pernicious. Sorry, I've got a little band across the bottom of the screen, so I had to move it to see what that said. In terms of the social factors, this was an article that my colleague Gord Flett invited me to join, a review article early in the pandemic showing that feeling valued was important to mental health and well-being of older adults, and feeling expendable, as many people felt early in the pandemic when decisions were being made about who to give care to, who to give access to the inoculation, and even just how to assign healthcare, including ventilators and that sort of thing. Many older adults were feeling excluded. Concern was also raised early in the pandemic that could the pandemic, difficulty accessing healthcare, difficulty accessing mental health care, and social isolation lead to increased rates of suicide? Well, my colleagues and I were fortunate to receive some funding from the Canadian government, where we reviewed the literature at that point, which showed that there had been some connections between epidemics and pandemics in the past and risk for suicide. Additionally, and highly relevant, were data from the SARS pandemic, or rather SARS epidemic, showing that older adults in Hong Kong were more likely to become suicidal, potentially or believed to be due to social isolation. What's interesting is studies since have not shown sharp increases in deaths by suicide during the pandemic. However, as many of us have seen in the news, surveys by Mental Health Research Canada and others have shown consistent increases in psychological distress, especially among youth. Some people, including recently, have said in their small communities, including smaller Ontario communities, they have seen increases in death by suicide. However, remember what I said earlier, rates of MAID have increased. So whereas we might not have seen increases in death by suicide, it does seem that there has been a somewhat different shift in people who have accessed assisted dying. So bearing that all in mind, we recognized early in the pandemic that we needed to try and do something to promote mental health and well-being in older adults and reduce the potential negative impacts of the global pandemic on the health and well-being of older adults. And so we decided to look towards an approach that should be promotive of well-being, respectful of the values of older adults, and promotive of their dignity. And there are a variety of approaches that have been looked at over the years, including meaning-centered approaches. So I'd already introduced, at least by mentioning Viktor Frankl, who developed a system of therapy called logotherapy, which literally means therapy through meaning, as an approach towards enhancing psychological well-being, reducing risk for suicide that focuses on meaning in life. This was Frankl in his mid-80s. He lived into his early 90s. Frankl also had survived the Nazi death camps, which he describes in his book, Man's Search for Meaning, which you see here. He noted, and he would frequently quote Nietzsche, who said, "He who has a why to live for can bear with almost any how." As long as we've got something meaningful that gives us a reason to go on, we can put up with just about the worst that life has to throw at us. His school of therapy has been described as the third Viennese school. After Freud's psychoanalysis and Adler's individual psychology, this was a caricature by Frankl, who's put himself on the third rung and much smaller than two men who he knew personally and with whom he'd studied. And based on his theory, my colleagues and I, some years earlier, had looked to develop meaning-centered groups. And at that point, it was really focusing on men who were struggling with the transition to retirement. So we called these meaning-centered men's groups. Without going into a lot of detail of those, I'll just say we were funded by Movember Canada. Here are my colleagues, collaborators, and co-facilitators, as well as our partners. And if you remember, we started with the question about what's meaningful in your life? What contributes to your sense of meaning in life? Well, when asked, Frankl pointed to a couple of distinct areas. He said we tend to find meaning in that which we contribute to the world, which he called either creative sources of meaning or creative sources of value, which doesn't have to be artistic creation, although it certainly can. It can be what we contribute through our work, through our activities, can even be sport, exercise, basically anything that we give to the world. He also said we find meaning through the flip side, that which we receive from the world in the way of our experiences. At one point, he said we find meaning in a task done and in a love. So the task being creative and the love or relationships experienced through experiential. But he also said we find meaning in the attitudes we take towards both the positive experiences in life, so being a good winner, as well as in adversity, challenges, losses that we experience in life. So even the ability to find meaning in suffering, and this is especially what Frankl is known for, and he referred to that as attitudinal meaning. But he also added another source later in his writing, which is a broader sense of connection to the world around us, through spirituality, transcendence, or a broader sense of purpose. And he referred to that as ultimate sources of meaning. So going back and thinking about the things that lend meaning to your life, you might find that they fall into those categories, or that you might think of them that way. Your relationships with other people, the things and the issues that are extremely important to you, the things that you enjoy doing, whether it's your work, whether it's volunteering, whether it's spending time with others, and maybe the ability to handle difficult challenges, to strike a positive attitude towards even negative experiences in life. We've argued that this experience should fit well with aging, that as maybe physical difficulties make it difficult to engage in certain creative pursuits, we can focus more on reflecting on life experiences. And that if certain sensory difficulties impede those, we can focus on our past experiences and the attitudes towards the future, towards life in general. And research has also suggested that we tend to or might turn towards spirituality more as we get older. I'll jump ahead because I know where we're at time-wise and just say, Frankl said some people believed I can't find meaning because I haven't done well in life, whether financially, relationship-wise, etc. And he said, no, the issue of success or failure has really nothing to do with meaning. The opposite of meaning is despair. So irrespective of whether you're the most successful person in the world or somewhat less so, if you're struggling, by searching for meaning, you can overcome that. He also said it's important to recognize that work is not the be-all and end-all in life, that if there are a variety of things that contribute to our meaning in life, family, friends, work, hobbies, activities, even if something happens to work or to a family member or to our hobbies, there are other things that can keep us buoyant. If, however, work is the ultimate and important thing in our life, I consider it maybe to be more like the keystone in a stone archway. You pull it out and the arch collapses. So it's important to have a number of things that we focus on. Frankl also said that if we try pursuing pleasure, power, money, success directly, we often don't get there. But if we search for meaning or respond to a meaningful challenge in life, some of these goodies might ensue as an unintended byproduct of the search for meaning. So I won't go into all of it, just to say there's a body of literature over a number of decades saying that people who find more meaning in life tend to do better, health-wise, mental health-wise, maybe even in terms of longevity. So we developed 12-week groups initially for men struggling with retirement, trying to help them feel more socially connected and find meaning through discussion of work and career, social contributions, volunteering, leisure, relationships, and their attitudes. We delivered these groups in person in community centers, delivered a number of groups in London, Ontario. One, we helped support providers and colleagues in Calgary to provide a group, and we found that participants reported improved social support, mental health and well-being, reduced loneliness, reduced depression, and reduced thoughts of suicide. We also found that participants enjoyed camaraderie, and some of them continued meeting with one another, going for breakfast, going for lunch, meeting online, even after the groups ended. Well, and that's what we found. Well, as of the start of the pandemic, we had a group that was meeting in person that couldn't meet anymore in person. So we started meeting online. Although some people struggled with the tech, some would have certainly preferred meeting in person, they appreciated continuing to meet. We were able to get a little bit of additional funding from the Lawson Health Research Institute in London to run a few additional courses of group for previous control participants in our study. And what we found in offering 2 more groups is that people experienced improvement in mental health and well-being, as you can see here. There was actually significant improvement in life satisfaction, retirement satisfaction, improvement in the sense of self-worth, reduction in symptoms of depression, and in interpersonal hopelessness. We didn't see massive change. We didn't see massive statistical change because it was a fairly small number of people, but we felt that these results were promising and said, let's take what we've learned here and apply them to older adults of all sexes and genders, especially focusing on people experiencing lockdown. We originally thought about long-term care, but realized at the time during COVID that was not something we could do easily. So we instead decided to focus on retirement homes. And we were fortunate, after searching around for a while, to get some funding. We got some funding and we partnered, as you heard, Pearlie and my colleagues and I partnered together. We got some funding from Employment and Social Development Canada, as well as from Bakerest Center for Aging and Brain Health Innovation, to develop our online meaning-centered groups, which are 8-session groups running once a week for about an hour and a half or so, which focused on finding meaning in activities, relationships, plans, spirituality, and overcoming some of the challenges due to the pandemic. So again, here are some of our co-investigators and collaborators in that study. The purpose was really to assess whether we can develop an 8-course online meaning-centered group that people attend, to see if they enjoy it, to see if these groups work well, ultimately hoping to roll them out and disseminate them to broader groups. So we wanted to evaluate people's satisfaction with these groups. see if they enhance social support and psychological well-being and reduce distress. Ultimately, we hope to look at cost effectiveness. We don't have data yet on those, and ultimately to train others to offer groups in their communities. So we originally, as I said, focused on retirement home residents, but had real difficulty with recruitment. It was all done online. We were all working from home. And so we expanded it to include anyone over 60 living in Ontario who could speak English, because we offer the groups in English, were sufficiently cognitively intact to benefit from a group, weren't receiving active mental health services, or struggling with severe mental health difficulties, because that might make it difficult to participate in a group. Here you see some of the ads that we showed online that we sent out to people, including to many retirement homes, to try and recruit people. Really trying to show the benefits of social connection and support. Groups were all offered online. People came from across Ontario, and the facilitators included myself and a colleague who I see is on the study as well, Glenn Granger, who works in community social service and mental health. We asked people for feedback on the groups all the way through and conducted assessments before the group, midway through, at the end, and follow-up. And we focused on creativity in a variety of ways, talking about work, volunteering, having purpose, feeling productive, caring for others, exercise, recreation, art, experiences, beauty, music, literature, sports, relationships, as well as attitudes towards both challenges in life and the positives in life, and thinking about the next stage, my legacy, what I can continue to contribute to life moving forward. We convened a study advisory committee who provided us with excellent input on what to do, and I will share some, and we focused on safety, obviously, which is absolutely necessary when talking about mental health issues. So we have now run two groups. The first one from December 2022 to February of last year, the second one from May to July of last year, and we're hoping to offer another group soon. For those who are interested, reach out or look at our website, meaningfulgroups.com. So what you've been waiting for, what have we found? Well, we had an equal number of men and women in our study, range from about 60 to 80. About a third were currently married or living common law. 2/3 were either single, separated, divorced, or widowed. Had a smattering of kids and grandkids. Most were born in Canada with English as a primary language. Almost all were retired or unemployed. Many were volunteering, and all had, just about all had attended, well, all had attended university, college, or graduate school. All had a family doctor, which was surprising because we know many people don't. Relatively few were receiving mental health services. A little over half endorsed some mental health issues. Many reported being spiritual. Some, about half, had experienced a loss to suicide in their life, and a small number had themselves been suicidal at some point. Just to say, and I won't get into all of this, generally strong cognitive functioning, in good shape physically, doing well. They were generally quite happy with their living circumstances and with their state of retirement. Frailty scores were relatively low. Reported on a 1 to 7 scale, the COVID pandemic had a major impact on their lives, and we saw very few who struggled with thoughts of suicide, depression, or drinking. And meaning in life was generally quite good. We asked about pain. Pain was sort of low to moderate, but it varied whether we talked about physical, emotional, spiritual, or overall pain. When we asked the question that I asked you at the start, what gives meaning to your life? Here are some of the things that people said, and I again categorize them into Frankel's categories. In terms of creativity, their activities, including volunteering, sharing advice with others, exercise, sports, being involved in organization, experiences including loving nature, relationships with others, their attitudes, being heard, contributing, positively influencing the world around them, and ultimate meaning, including God, longing for purpose and meaning in life, and spiritual practice. We looked at group process variables to see how people enjoyed participating in groups. On a 0 to 50 scale, 50 being the highest score, generally scores on average 45, so basically about 90% in terms of satisfaction, so people enjoyed the groups. And on a measure of working relationships, that was as high as 7, people reported generally enjoying that as well. So they found the facilitators helpful in enjoying the groups. We then asked people or looked at change from the beginning to the end of the study in some well-being variables. Remember, we only had 2 groups, only had about 17 people in the groups, and so we're not going to see a lot of change, at least at the statistical level. However, we saw on just about every positive variable, we saw some improvement. On the negatives, we saw reduction in those. So everything moved in the right direction, even if it didn't achieve statistical significance. Nevertheless, we did see statistical improvement in feelings of hopelessness and in anxiety, which is important. So by the end of group, people were feeling significantly, although slightly, these are not massive score changes, but they were feeling less hopeless, less anxious, and we saw other improvements, although not significant, moving in the right direction and getting close in terms of life satisfaction, psychological well-being, especially in terms of relationships with others and personal growth, and reduction in a loss of sense of sort of disconnection from others. What wasn't as apparent from those numbers is the feeling in the room, which was positive, pleasant, and supportive. People were generally interested in the topics, enjoyed supporting one another, and reported benefiting from the meaning-centered perspective that we shared. So we were seeing change in attitudes and improved well-being. Taken as a whole, these groups may help enhance social connections and well-being. Clearly, we need to run more groups before we can say that definitively in any statistical sense, but our experience in the room was that people enjoyed them and generally benefited from them. And we do, as I mentioned, hope to continue offering these groups and are very interested in taking questions and people's interests if they are. So overall, research supports a focus on meaning in life and enhancing mental health and well-being. Meaning-centered interventions definitely have their place. Our online groups seem promising, and we hope to continue to run these and other groups to enhance mental health, well-being, social connection, decrease feelings of loneliness, we hope, and ultimately help to enhance life and reduce thoughts of suicide. And a final thought, and then I will stop. We are running some additional projects which also aim to enhance well-being and reduce suicide risk, including for the last few years, meaning-centered groups for male veterans and first responders. These are still ongoing. With funding from CIHR, we're conducting a study in long-term care homes to train frontline providers to assess suicide risk and respond sensitively. And we're developing a measure looking at thoughts of hastening death, ultimately to try and help older adults who are feeling that way at the end of life. So I thank you very much for your kind attention. Would like to acknowledge our funders, our study participants, study advisors, Glenn, who's helped me co-facilitate these groups for many years, and all of our research personnel. And I'm happy to stop sharing and throw it back to Danny.
Great. Thank you so much, Marnin. That was a fabulous presentation. And I love just that message of hope, and that, although some of those statistics that you shared are pretty staggering about suicide rates for older adults, there's that underlying tone of positivity that this is not, an inevitable part of aging, and meaning in life is so important and can play that preventive role. So thank you. So we do have a few questions lined up. We just have a couple minutes, so we'll try to get through them. The first one is, what is the connection between loneliness and caregiving? Will you be creating an OMG group focused on caregivers?
Excellent question. It's among the studies that I've seen, certainly we know that, and one thing we know for sure is that caregiver distress can be a massive concern. Um, People who are providing care for loved ones who are struggling really experience that. Difficulty with caregiving certainly can be associated with loneliness. And, thinking about it functionally, it can be very difficult when caring for a loved one at home, very difficult when having to make a decision if one has to make a decision for the loved one to receive care elsewhere or go into a home, and then facing all the challenges of visiting, providing care, working with the home, benefiting from all of the resources available, and just all of the challenges that that can bring. So certainly that can be a big issue, and providing support, as you suggest, for caregivers is extremely important. So one of the things that we recognized and we were hoping is that some caregivers would join our groups, and we did have some, and that's something that we were very much open to. So people who are in that boat, who are providing care for loved ones, who are over 60, please reach out to us. If you're under 60, reach out as well. But I agree that's exceedingly important, and I agree the groups can be very effective.
Okay, thank you. So the next question is, would the educational and linguistic backgrounds, as well as ethnic, be a limitation in the OMG study? So for example, older adults were from backgrounds where talking about mental illness is a stigma and who experience a language barrier in expressing their thoughts.
Another excellent question. In terms of language, the main language barrier is just that we've offered these groups in English, so somebody should feel sufficiently comfortable in English to be able to join the groups and participate in it. Certainly, we've had people for whom French was a first language who feel comfortable participating in English, and there's no reason why groups can't be offered by people proficient in other languages in other languages. And we really don't focus on discussion of mental health difficulties or mental health diagnoses in the groups per se. The groups really focus on how do we find meaning in activities, in interests, what sort of things lend a greater sense of meaning in life, what can we do to help other people so that we can feel good about doing that or benefit from the care we provide to others, and many issues like that. So although I know I've focused maybe a little too much on mental health difficulties and on suicide in my presentation, ultimately our hope is that the groups will help to reduce those things. But the groups are really designed to be non-clinical. And really, something I hadn't said per se is that these are designed to be upstream interventions to try and prevent people getting to the point where they maybe have to access mental health care, which is one of the reasons why we say if people are struggling more, we would refer them to a mental health provider. And as they're starting to do a bit better, welcome them into a group. So that really shouldn't be a barrier. But we do know that some cultures and some people, let's face it, are less comfortable sharing their personal issues with others. And we have seen in groups, some people are much more open about what they're going through, what their experiences are. Others keep it a little bit closer to the vest, but hopefully still benefit from them.
Okay, great. And finally, we're just wrapping up here. So have you thought about connecting with local councils on aging across the province to recruit additional members for your groups?
Yeah, that has been certainly one of the thoughts we've had, as well as age-friendly communities in various locations. And we've gone to various groups, we've gone to various activities for older adults, including learning groups, including social support groups and centers and programs. But certainly that's an important one, and I do thank you for that thought. And again, if people have any other thoughts about how we can get the word out, if you're interested, if you know people who might be or who might benefit from it, feel free to reach out to us. Let us know. Feel free to reach out to Danny. Feel free to reach out to me. Because again, ultimately, it's nice to be able to share a few findings. It would be nicer to be able to share more findings, and even more important than that, if, as we seem to see to be the case, that these groups do have promise and can help, we want people to be able to benefit from them, and we'd like them to be made available to people really across Ontario and beyond across Canada. So thank you
Absolutely.
again
And
for
I
your.
think you mentioned the website, Marnin, and maybe we can send that out with the recording, which we'll be sending out after the after today. But I believe the website is www.meaningfulgroups.com.
Exactly.
Correct? Okay, so you can reach out through that because that was another question. How do we connect?
Absolutely.
We'll send that out in the follow-up email. And then there was just a final comment from Sabby. There can be a lot of loneliness by the older person within a family. How can we promote intergenerational intervention or groups focused on looking at intergenerational, I guess, programming, since family is a big meaning in people's life, but can be lost in our society?
I agree completely. It's extremely important. In our groups, we certainly talk about relationships, including in family, but I think that there is a need for that to really work with families to recognize that older adults, their older relatives might be struggling. That I gave a presentation early in or just before the pandemic, sharing some of our findings on loneliness with some of our graduate students at Western. And one afterwards said, "So are you saying what I should do is reach out and call my grandmother and see how she's doing?" And I said, "That's a nice idea." So I think one of the things is to really just get the word out across generations that just because you're not hearing from older people in your life doesn't mean that they don't want to hear from you. Or if you are hearing from them, they say, "Oh, no, 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 you're busy with your things. You do your thing. Don't worry about me." Maybe you should still worry about them. Or maybe we should all try a little bit harder to reach out to our loved ones, to older community members and older family members. And I agree that ways of connecting family is extremely important. And there have been both programs in various communities and developing research looking at grandparenting programs that match up older adults with younger people, as well as actual grandparents with their grandkids, which can be very much promotive of mental health and well-being in both the grandparents and the grandkids. So excellent, excellent questions and excellent thoughts. Thank you.
Okay, great. So we've just gone over time. Sorry, everyone. We're going to wrap it up, but I just want to close by saying thank you so much to Marnin for presenting today. That was a lot of really great information and really inspiring as well to hear you speak as always. So thank you very much. And thank you all as well for attending today's webinar. We hope you enjoyed it. Please stay tuned for information on our upcoming webinar in June. And in the meantime, if you'd like to learn more, as we said, we'll send out the information on the meaningful groups. And you can also learn more about the Center of Excellence by visiting our webpage at pearlyhealth.ca/Center of Excellence. And just a friendly reminder, we would really appreciate it if you could complete the short survey that will appear when you exit the webinar. So I'm wishing everybody a great day. Take care of yourselves. And thank you again, Dr. Marnin Heisel.
Thanks very much. Take
Bye,
care.
everyone.